So Dr. Finelli's here, and he's the head of urology at University Health Network and the GU Cancer Site Lead for the Princess Margaret Cancer Center. So he's also not only a clinician, but he's a very active researcher. They probably don't need to know about number manuscripts. You spend way too much time writing, Tony. Oh my goodness. But I mean, the biggest thing is that Tony really focuses his practice on kidney cancer and prostate cancer. So he's one of the leading experts in the area. In particular, for surgical techniques, his contributions on minimally invasive surgery are renowned internationally. So we truly do have an expert in our midst here. And Dr. Finelli, and this is an interesting fact because I didn't know that they've started this now, that Dr. Finelli's recently been selected as the inaugural genitourinary, or GU for short, cancer lead for the province of Ontario. So congratulations, Dr. Finelli. That's wonderful.
Thanks. Thank you. Appreciate it. Appreciate your kind words, and I'm glad to be here today. And thank you for those that are here physically and for those that are with us remotely. What I'd like to do is take about 15-20 minutes maybe just to touch on some of the surgical aspects of kidney cancer care. I tried to keep it simple, minimal, but really will make myself available for questions if you have any. So most of you know kidney cancer is relatively common. It's not the most common, but at the end of the day it is in our top 10. And like a number of our cancers, it's really a tale of two tumors. There's those that are diagnosed with a kidney cancer who have a very low stage, low grade cancer that they do well with. And then unfortunately there's those with the more advanced situation. And that's why sometimes these overall numbers can misrepresent the real lay of the land in terms of how important it is as a cancer. What people present with, unfortunately, when it's advanced, we know it's usually advanced signs of being unwell. Weight loss, blood in your urine, etc., and other features that are quite concerning. It is something that usually presents in the 60s, although we have young patients and we have patients older than that at their presentation, and it is slightly more common in men than women. Just to remind you on the staging system, these systems continue to evolve, but in general, when you think of any cancer that's a solid tumor, just try to break it down into stages 1, 2, 3, 4, or into what we call a TNM system, which means the tumor itself. N is for lymph nodes, and M is for disease that's spread outside and elsewhere in the body. Stage 1 is usually a well-behaving tumor. It's in general one that's less than 4 centimeters. It's within the kidney itself, and it's highly amenable to cure. And as I'll suggest later, perhaps some patients don't even need treatment for some of these lesions. The other extreme, unfortunately, the pink box is your stage 4. So these are those ones I talked about. These are the real challenging cases. These are the individuals who have spread of their cancer and the most concerning. 2 and 3 are somewhere intermediate. The tumor slightly larger, slightly invasive, more grade, etc., just a little more worrisome, and it's someone that we have to watch because they have an above average risk of a recurrence after their intervention. These curves are called Kaplan-Meier curves, but to keep them simple, imagine 100 people on the y-axis, and the bottom line, the bottom axis, is just time. And what you have in the top corner is if everyone had treatment for this stage at that point in time, how many of them unfortunately recurred or passed after this period of time. So the top curve is the best behaving curve, and those are your T1s again. As you can see, as you go out to 10 years, most of them have not experienced the recurrence. And that's why one could argue that maybe we're doing a little too much for those people, and I'll come back to that. The flip side is you can see the challenge in the T2, 3, 4 kind of range where we're losing patients or they're having recurrences, usually within a few years or 5 years. So just to put some Toronto perspective on this, very fortunate to have trained at this center, and actually our former chairman was Charles Robson, and he's the Robson of the Robson staging system. If anyone goes on the internet, it's a little bit of historical system now because we've moved away from it, 1, 2, 3, 4 as I mentioned, but he is the man behind that, and he's also the one who kind of put aside and set the principles on what should be involved in performing a radical nephrectomy or the removal of your kidney for cancer. So this is a traditional approach to having surgery for your kidney, and it's just to give you an idea. and I've tried to really keep it to cartoons today. Not everyone's a fan of pictures and graphical presentations of what actually happens in the operating room.
Thank you.
Even though the cartoon looks pretty tough, if you ask me too. So most surgeons operate through an incision that's above your 11th rib, and that's a tough incision. The pain is significant postoperatively. Some have chronic pain, and I'll show you some of the other side effects. But basically, we approach it that way because your kidneys are much higher than you expect. They live under your rib cage, and they're in the back area, behind all your other abdominal organs. You can approach this other ways, but there's challenges in doing so. As I mentioned, one of the concerns with this type of surgery, and I'll come to some of the other features later, is something called a flank bulge. And although people think this is rare, it's pretty common. If you talk to patients who've had this type of surgery and you actually ask them, they'll tell you, you know what, when I look in front of the mirror, it does bulge out a little more on this side. I have a little bit of tingling, there's a numb area, or I can have a bit of a shooting pain, and it's a chronic issue. Now, they're grateful that they're cured and they have it out, but if you ask them sincerely, they'll tell you they struggle with the incision. It's tough. This is just an MRI showing what the bulge looks like. If you look where those white arrows are, you can see how on that side of the body where the kidney's been removed, the abdominal wall tends to bulge out. So one way of getting around this is to try to perform surgery in a minimally invasive way. A lot of catch terms, laparoscopic, keyhole surgery, MIS, minimal access, they all mean the same thing. Essentially what the surgeons or the literature is describing is that rather than making one large cut to get a kidney out, we make 3 or 4 small incisions that are about 1 centimeter. We place a camera, a scope into the patient, use instruments to reproduce the steps that you would if you performed the operation through a large cut. And then at the end, rather than take it out through an incision between your ribs, we choose a strategic incision that's less painful. Something comparable to one for removal of your appendix, for example. So for right-sided surgery, we'd make an incision about this big, low down in the pelvis. And without cutting muscle, we spread muscle. So patients tolerate this very well. It's still a major intervention, but they recover much more quickly, return to work, return to the normal activities sooner. So ideally, if someone needs their kidney removed in its entirety for their tumor, this is the go-to approach if it can be offered. It's been around now for more than 20 years. The adoption rates are variable. It is more challenging for surgeons, but I think the vast majority of urologic trainees now, residents coming out, can perform this surgery. And as I said, you can see the benefits there. Those are just drawings of where the incisions go, and you can see how they're much more favorable. And once you really get advanced at this, you can use smaller access so that the pain is even less. And then you could take the incision out, as you see, the specimen out here through a strategic incision low down. So we feel that this should be the standard of care. Most patients who present with a localized tumor that's, the gray area is anywhere between or above 8 to 12 centimeters, but I think almost anyone with a tumor less than about 8 centimeters should be offered this approach, unless there's something in their history that contradicts it or doesn't make them a candidate for it based on their abdominal history if they've had multiple procedures. But this is what if you're unfortunate enough to be diagnosed with this condition and you need surgery, you want to try to get it done this way and you'll feel better. So, as I said, this has been around for well over 10 years now, 20 years, and I think it is the standard. So I'm lucky again because I think I've trained with probably 3, or either the legacy of some of these men, but I've trained with some of the biggest names in kidney cancer. So this is Andrew Novick, who passed away about 5 years ago, and he used to be the chairman at the Cleveland Clinic, and that's where I did my fellowship. And he was one of the pioneers for what's called partial nephrectomy or nephron sparing surgery. So this is something we offer to patients who have very small tumors or those that unfortunately have one kidney, because we don't want them to go on dialysis. So if you are someone who only has one kidney and you show up with a kidney tumor, we go out of our way to just try to remove the tumor itself instead of the entire kidney. And this has been around as well now for 20 years, and I would say, and I'll come to it later, that it should be the standard for the small tumors that require surgery. It's been shown to be equally effective for cancer control, and obviously the benefit here is preservation of your kidney function. And you just don't know down the road how much kidney function you're going to need if you get extra treatments, if you get a tumor in the other kidney, etc. This is now being expanded, and I think the pendulum might swing back a little. We became very enthusiastic and started doing partial nephrectomies for almost anything we could because we believed in saving kidney function. But at some point, perhaps you really should just be taking out the entire kidney. And this is going to be a conversation with your surgeon. That might be a size limit, a location limit, or just something about your history. And that's the importance, I think, of consulting with a surgeon who can actually offer you the full spectrum of options so that you're not stuck in a position where you're only offered a certain option because that's all that's available. So what's beautiful is that we've now evolved away from open surgery even for this type of operation. When we first learned how to take out the tumor itself, it's pretty tricky. The kidney basically has all of your blood flowing through it because the kidneys are your filters. So we need to control the blood supply to the kidney. We need to move quickly because if we keep the kidney without blood for too long, it really doesn't function well after. And over time, we've been able to now transition this and perform it through small cuts again, like the operation I described for the entire kidney. So that laparoscopic, minimal access kind of approach. And this isn't so new either. This has been around for about 15 years, and I'm quite lucky again because this was my mentor when I trained at the Cleveland Clinic, and that's Inderberg Gill, and he's the one who really pioneered the steps in doing this operation. So I spent a couple years there and learned how to do this, and we were able to bring that back to Toronto and grow our kidney cancer program at our center. Very similar incisions to what I showed you in those cartoons earlier, but this time it's even more advantageous because if you're operating on a tumor that's less than 4 centimeters, you really need a cut about this big to take the specimen out of. So you can see how patients can bounce back quite quickly now instead of that 10 centimeter cut above the 11th rib. And this is where we are today. And this is robotic surgery, incredibly expensive, but incredibly advantageous to surgeons. I can't get into a lot of detail because of time limits, but when you operate laparoscopically on someone, you're basically operating through these plastic cylinders and you're fixed. You have no rotation, minimal rotation, or articulation of your instruments. So it's a challenge. You got to learn how to adapt in that environment. What this device does, it has wristed technology at the end of those instruments that I showed you, so that the arm goes round and round 360 degrees. So you can imagine as a surgeon then, you're almost able to duplicate what you did through the big cut. Because now you're holding scissors that can turn in many ways to cut the tumor out very precisely and to suture all those little blood vessels very precisely. The problem is the price tag on this to get started is about $5 million. We're lucky we have one of these. We had a donation, so we can offer a robotic partial nephrectomy. So what I've taken you through to this point are what we call extirpative options, meaning removal options. So these are the surgical approaches when we remove the tumor, the kidney, or part of the kidney. What I just want to touch on are 2 options where you actually don't have anything removed, but we're applying energy to either freeze or burn the tumors. Cryoablation is the first one, and what this means is basically freezing your tumor. So in certain patients who have poor kidney function, perhaps a single kidney, or are high risk to undergo a general anesthetic and a complete operation, this is a great option. Because what they're doing here is with an ultrasound probe on your back, they puncture the skin and place this freezing probe right into the center of the tumor, turn the temperature down, and they create an ice ball that freezes and kills that small tumor. Take out the probe and you're home the same day. So this is the next step that we are using. I will caution that it shouldn't be offered in all cases, but in select cases, it's clearly a home run because it's outpatient, kidney function preserving, no general anesthetic. I don't need to show you that. Okay, so I'll go to here now. So now the opposite of that is let's burn the tumors. This is called radiofrequency ablation. Same concept. Someone shows up, they've been diagnosed, they go see their surgeon, they're referred to either the surgeon or a radiologist, who then inserts a needle into the tumor, turns up the temperature, and burns the tumor. This cartoon is showing how they do it for liver, but it's the same for kidney. And that's the physics behind it. And as I said, it's IV sedation. So that's short-acting morphine, short-acting Valium-type drugs. So those are the other two treatment options, but restricted to tumors usually less than 3 centimeters. What I want to touch on now is something you may be hearing more of, and it's actually it's the role of a kidney tumor biopsy. And the reason I want to touch on this is there's some misinformation or historical information on the internet about the risks of having your tumor biopsied and that you shouldn't have it performed because the tumor might spread and all of these bad things can happen. So I want to address this because I advocate for this. I think it's a very important first step in people presenting with small tumors. So I circled those two top lines again just to remind everyone, if you're someone who gets the diagnosis of kidney cancer but you're in that T1 group, you are almost certainly going to have a great outcome. As an oncologist, when I manage people with tumors that have a great outcome, I try to go out of my way to diminish the harm of my intervention. Whereas when I have a patient in front of me who has a serious prognosis, I go out of my way to cure that patient. And we accept more morbidity or more harm of our interventions because it's really a threat to their livelihood. So this discussion is focusing on those more benevolent tumors right now, and I'll explain why I think you should have a biopsy if you're found to have a solid small tumor in your kidney. So we're seeing an epidemic of small kidney tumors. Basically, there was an era when you went to your family doctor, you complained, you had some bloating, you just had this, you had that. They would feel your abdomen, say, you're okay, go home, which is good and bad. Nowadays, not to take anything away from primary care physicians, they're much more likely to send you for imaging. So you get sent for an ultrasound, you get sent for something, and boom, the surprise. Incidentally detected 1 centimeter tumor in someone's kidney. The referral goes to Finelli, and then the ball starts rolling. The anxiety goes up to here because you've been told you might have cancer. And so we're facing more and more of these diagnoses now. It's not that it's more common, they're being found more commonly. That's what I believe. And so before the imaging era, more than 50% of kidney tumors were undetected until autopsy. So what does that mean? That means most people who were actually diagnosed were dying from other causes, but when the pathologist did the autopsy, they also recognized, oh, look, he has a small kidney tumor, or she has a small kidney tumor. In more lethal cancers, autopsy-detected tumors are very rare, meaning they all would have presented while the patient was alive. So this suggests that there are tumors of the kidney that are common, small, and really of less consequence. Tumors less than 3 centimeters rarely spread, and the real home run, 20 to 40% of them are actually benign. Oh, one specimen, sorry, that got through the screen this morning. So, so what are the indications for biopsy? There are other indications for biopsy, and I'm going to get back to the little tumors. One is, if you are unfortunate and you have widespread disease, we need a biopsy to find out what kind of kidney cancer it is, because it has to do with your eligibility for drugs. Okay, so that's a typical one. Sometimes it's not a typical kidney-looking tumor. It's not a spherical growth in the kidney. It's this carpet of disease, and that's often lymphoma. So that's a reason to do a biopsy. But in my mind, and what I'm going to advocate for, is the reason for small tumors. Okay, so this was a study from the Mayo Clinic, and I don't know if it's projecting well, but what it shows is that many of the small tumors that they took out, because they didn't know what it was, because they were operating on everything regardless, it was just based on imaging, turned out to be benign, especially in the less than 2 to 3 centimeter range. Also, when you looked at the ones that were malignant, the vast majority were low grade. Grade is a word in medicine that's different from stage. Stage refers to how large the tumor is, has it spread, has it invaded. Grade is something the pathologist assesses by looking in the microscope and seeing how abnormal the cells are. And that speaks to how malignant that tumor can be in its ability to spread. So they were low grade. So first of all, many of them were benign, and then if you took the ones that were malignant, many were low grade. So I'm building a story of telling you that most of these are favorable. So biopsy. Safety, technical points, diagnostic accuracy. This is how a biopsy is performed. Some of you here may have had one. It's usually ultrasound guided, and again, it's an outpatient procedure. It could be CT guided as well. This is the needle that they use. It's 17 gauge. I know it looks horrific, but from what I've been told by patients, it's really quite uneventful. They feel a little bit of discomfort, but nothing compared to some of the other interventions they've had. All right, so that's just a cartoon showing how the tumor is skewered and the specimen is sent. So let me just fast forward here. Biopsy. At our center, biopsy is diagnostic 90% of the time. One of the complaints or criticisms when I debate biopsy is that it's not always diagnostic. It's true, it isn't always diagnostic. Unfortunately, about 10% of people have a report that says insufficient material, or the pathologist doesn't want to commit because they feel responsible. So they'll give you a reading that the tumor is most consistent with this, but not necessarily that. So 90% of the time we get a firm answer. Bleeding. I think in our series now, which approaches over 700 patients, we have had one patient who received a transfusion after a biopsy. It's incredibly rare. And really all other complications were not even measured. The spreading issue we haven't detected. So we advocate for biopsy up front. So to summarize, if you have a small, solid, enhancing tumor in your kidney, the first step, we believe, is a biopsy, because 20 to 30% of people can avoid treatment simply based on that first step. And then going forward, that information may actually alter our treatment. If it comes back as high grade or of a histology that's aggressive, we might lean towards complete removal of the kidney as opposed to a partial. Whereas if it comes back as low grade, a much more benevolent histology, then we're going to push for a partial nephrectomy because we want to save a good kidney. The last piece is something called surveillance, which I think is a difficult concept to grasp, especially if you're a cancer survivor. And that's because we live in a world where we use phrases like the war against cancer and the fight is on. And those are very appropriate terms for people who've been given a tough diagnosis, meaning a life-threatening cancer diagnosis. The flip side is what I said earlier. Small tumors that behave well, we probably do more harm than good by treating them. So what I want to touch on is a concept that my partner Mike Jewett championed, and it's really one of selecting patients who might benefit from no intervention. And just to keep that in mind. And obviously, when we rolled this out, it was for unwell patients, those that we thought were likely to succumb to another diagnosis before their kidney cancer would be the cause. So this is our study that went across Canada with about 200 patients. This was the longest term report to date. And what we showed was that these tumors grow very slowly. So on average, they grow about 2 to 3 millimeters a year. So now if someone were to do the math, and let's say we had an older patient who had had a stroke, a heart attack, has a stent, has some heart failure, they're 78 years of age, this 2-centimeter tumor that's growing 2 millimeters a year should be left alone. Because anything we do to them may shorten their life rather than prolong their life. So this concept is one that should be kept in mind for patients who we feel are high risk, have small lesions, and have what we call significant competing health risks, meaning other diagnoses that are much more serious. Some actually shrunk. This is a waterfall plot, and if you look here, these are tumors that shrunk while being observed, and these are tumors that grew. we're starting to learn from our experience because we do biopsy, and what we're learning here is that a certain tumor called a papillary tumor, although it can be serious in some patients, it often grows the slowest compared to other histologies. But we still have to become more sophisticated in our markers to pick out those patients. All right, so just a few slides to go. This is an interesting way of depicting what happens to patients in terms of their survival and based on the type of tumor they had. So red is probability of dying because of your kidney tumor, and blue is likelihood of death from another cause. And you can see, I don't see it from here, it's quite far from me, but my recollection is that when the tumors are small and the patients were older, the vast majority were passing from other causes. And really the kidney cancer threat was much less as compared to the larger tumors in younger patients where indeed the kidney cancer threat is greater. So in conclusion, surgery is the cornerstone of kidney cancer management. Depending on the stage of your tumor and other variables, there are several options. And I think that's why it's so important to have a thoughtful conversation with your doctor. Biopsy is becoming the standard diagnostic tool in the assessment of small kidney tumors. And we're striving to personalize care such that we can avoid overtreatment of the more benign tumors and intensify our efforts in those with the more malignant or serious tumors. Thank you.
Thank you very much, Dr.
Okay,
Finelli.
sure.
Do you have time for
Yeah, I can take a few
right now?
questions.
Okay,
Sure.
so we'll start in the room first, and then we'll see if anyone on the webinar has any questions.
Perfect. Go ahead. Yeah, go ahead. You go ahead and then I'll go to the back. Sure, please.
I was diagnosed with renal cell carcinoma recently, and I'm looking for surgery. Is it possible that my doctor send you a request for myself?
Sure. But maybe I can speak to you after, because depending on the diagnosis you have and where you're at, you might be better off staying rather than experiencing a delay to your treatment. So I'd be happy to see you, but after the session finishes, I'll take a few minutes to just ask you a couple of questions. And if I think you're better served coming down, then we'll take care of you, absolutely.
Okay, I got the description of my...
Perfect. We'll do it in a minute. All right.
Thank you very much.
Great. My pleasure.
In cryoablation, what happens if you can't use an MRI for location?
Could you repeat the question?
Yes. So the question was, for cryoablation, what happens if you can't use an MRI? It doesn't have to be MR guided. It can actually be ultrasound guided. The MRI, I think, was for the follow-up here. That's what you were seeing. Those were MRI follow-up scans to look at the lesion over time. You know, it's cryo is not it's not MR guided necessarily. You can do it other ways, yes. And RFA, radiofrequency, very similarly, it's done CT or ultrasound guided. You can actually have cryo done laparoscopically. If it's a real challenge to image, you could approach the kidney through those small holes and then insert the cryo probe in under ultrasound guidance. Yes, sir.
Well, I turned down a CT scan for my surgery just because I thought my kidney, my solitary kidney, might better off without it. Besides all my results have been very clear. Although my labs have been I'm wondering how do you protect your...
How do you protect your kidney? So,
You're talking
yeah.
about both kidneys, right?
So the question from the audience, if I interpret it correctly, is from a gentleman who has a solitary kidney who underwent treatment for a tumor and is asking about how to protect your kidney function. So in terms of a CT scan being bad for your kidney, it's not necessarily the scan, it's the contrast. And it depends on what your kidney function is. I think if you had a favorable tumor with a low likelihood of recurrence, I would agree with you, and I would probably follow with abdominal ultrasound in that situation, plus or minus an occasional chest x-ray. In terms of what's good for your kidney health, it's really the same as what is good for your heart health. The entire kidney's ability to function well is based on blood supply and blood vessel health. So you want to avoid diabetes, you want to avoid high blood pressure, and so a heart healthy diet and exercise, no smoking, those 5 right there will protect you more than anything else. Stress. So, yeah, so, stress, you don't have any stress. No, stress is an interesting variable, but no hard data on it.
I think we have a couple questions on the webcast. So from Marianne, can cryo and RAF be used to maintain or eliminate lung mets or other mets in advanced disease?
So it's a very good question. So what we're touching on is a concept of treating low volume metastases. The medical term is oligomets. So for patients who've had recurrence or spread of their kidney tumor, although we often give them medication, some of the drugs you're going to hear about, in select cases where it's a local recurrence in one place, or only one of those lesions that's recurred is growing, maybe to keep patients off drug or not rely on the drug, you can actually target the oligometastasis. So you can target it either with surgery, depending on where it is. You could target it with RFA, for sure. There's an experience with RFA in the lung as well as in liver metastases. RFA has been used. An emerging area is something called SBRT, which is a stereotactic approach to radiotherapy. I'm not familiar with cryotherapy in the lung, but I know RFA has been used.
What is meant by RFA?
Radiofrequency ablation. Yeah.
And we have one more question up there. Is there evidence that for stage 3 to 4 patients, nephrectomies will hinder the spread of the cancer to other organs?
So, indeed. So they're actually in stage 3 disease for certain. Surgery is curative in 50% of patients. If it goes untreated, it will spread and life expectancy will be much shorter than if one were to undergo surgery. I think stage 4 is a challenging question, and I'm interpreting stage 4 not as locally invasive, I'm interpreting it as metastatic. And I think we've been struggling, we have a few clinical trials that are ongoing where we're trying to compare drugs versus surgery removal of the kidney followed by drugs, and that's called a cytoreductive nephrectomy. I think our current sense on this, if you were to speak to both medical and surgical uro-oncologists, if the majority of the tumor resides in the kidney, if the patient has an excellent performance status, so they're very highly functioning, and they're a good surgical candidate, I think even most medical oncologists would say remove the primary and then we'll consider drug therapy after. Obviously, if someone is a poor surgical candidate, has, let's say, a 6-7 centimeter tumor in their kidney, but multiple areas of spread, then I think it's questionable and definitely debatable if removing the kidney itself is going to alter the natural history of that condition.
We just have a comment from one of the listeners on the webinar saying thank you very much, especially talking about active surveillance and biopsy. She's been on active surveillance for 5 years.
Good for you. Great.
Just talking about how 5 years ago it wasn't as commonly spoken about.
Yeah, awesome.
And I think we have one last question. Is conventional radiation widely used for the treatment of metastatic nodules?
So I'll touch on radiation in general, and then I'll go back to your metastatic nodule comment. So in general, we've always felt that kidney cancer is chemo-refractory and radiation refractory. It continues to be chemotherapy refractory in the traditional sense, chemo that you put intravenously as opposed to these new targeted therapies that are pills or immunotherapies. In terms of radiation, we've learned over the years that actually delivered in the correct manner now, you can have kill or control of the cancer with radiation. I think it isn't considered a standard or as effective as surgery when you're looking at the kidney itself, but without a doubt, it's something that should be considered, as we touched on earlier, for patients who have isolated spread that's amenable to radiation, or just certain areas of spread that are growing, whereas others are remaining stable. So I would recommend, if you were in that position, to seek a referral or ask your oncologist, maybe, is there value for me having radiation to the nodule that's growing in this setting? Done? Great. Thank you. Have a great weekend.
Thank you very much, Dr.
Oh, you're welcome.